Hello, my name is Gary Swan, and this is my final business proposal for Washington State University's OMBA program. I had the fortunate opportunity to work with Lincoln Hospital in Davenport, Washington, to help them vet the potential of a rural home health program. First, I'd like to talk to you a little bit about what rural health care is. So Lincoln Hospital is a critical access hospital, which means that they're a small facility that offers limited outpatient and inpatient services to people in rural areas. So Lincoln County has a population of about 10,000 people across 2,300 square miles, or about 4.5 people per square mile. In Spokane, the population is about 209,000 people across 60 square miles, so just under 3,500 people per square mile. So in comparison, the delivery of healthcare for a rural community, such as Lincoln County, is much more expensive and much more difficult to accomplish. Lincoln Hospital was established in the 1960s not only to provide those essential services, but to boost the economy, to provide a long-term care facility for the adult vulnerable or the elderly population within the community. Now, unfortunately, in 2012, Lincoln Hospital was forced to terminate those services due to substantial operating losses. Now, this really left a void of services for the elderly population within the community and really gave them only one of two options: either to remain in their home, potentially in an unsafe environment, which often results in repeated admissions to the hospital, or to sell off all of their assets and to relocate to another long-term care facility far beyond the county boundaries. So there's a real need for some sort of support services or some sort of delivery of care in the home within the community. Working with the administrator of Lincoln Hospital, we identified three main components that would facilitate this need and provide some sort of service to this population. Now, this model or this program falls underneath the home health model for Lincoln County, which means that it's directed by their care coordinator and by the patient's primary care physician. So the three components we identified to facilitate this program are three: the visiting nursing services, support chore services, and remote monitoring technologies. Now, visiting nursing services would be conducted through remote means, so via the remote monitoring technologies. This would have three main functions. Basically for follow-up, to ensure longitudinal care or monitoring the patient over the course of time to make sure that they are following the care protocols for therapy sessions, or on an emergent basis. So, for example, say grandma hurt her ankle and is uncertain whether or not she needs to come into the hospital. Well, we can have a remote visit with the nurse to determine proper care procedures and determine whether or not this needs to be escalated to the next steps. Now, visiting chore services ensure safety in the home or a safe living environment for the patient. So this would mean basically a clean home, and it would also mean potentially transportation services, facilitating dietary needs, things of that nature. Now, the last component, remote monitoring technologies, comes in two forms. And this piece really encapsulates all the other components of the program and facilitates it and makes it able to function viably. It comes in active monitoring and passive monitoring. Active monitoring is the safety component, which is the sensors and the personal emergency response, O2 sensors, things of that nature to determine an emergent need within the home. Now, passive monitoring is, as we spoke before, the longitudinal monitoring of the patient to ensure that they are following a care plan. So that would include biometrics, things such as blood pressure cuffs, ECGs, glucose monitors for those patients with diabetes. Now, this allows the primary care physician to set thresholds and to track that patient over the course of time, and should there be a need, intervene and correct a potentially emergent situation. At present, the only other option for this population, the elderly population, is to relocate to a long-term care facility. And unfortunately, the cost of this is simply unsustainable, especially with the baby boom population aging. this cost is only going to rise. So there's a real need or a desire within the industry right now to find solutions to these types of problems, find new ways to deliver care. At present, we are in a fee-for-service model. So that means when you go into the patient or go into the doctor sees you for X, Y, and Z. He bills X, Y, and Z to the insurance company and gets reimbursed. Now, moving into the future, we're moving towards bundled payments and shared savings programs. So this means coordinating with different other specialists and trying to reduce costs. So the physicians, the providers, will be reimbursed a flat rate for a patient population. And then if you're able to bring your costs in lower than that reimbursement rate, then you can share in the savings. And the potential savings can be significant as you grow the population. So the target market that we're looking at is not only the adult vulnerable in need, but also the families, because it's really the families who make the decision to transfer grandma or grandpa to a long-term care facility. And oftentimes this is simply because they work or they can't be there enough to provide that extra helping hand that grandma and grandpa need. So this is really intended to empower not only the patient, but empower families to ensure that everybody is safe and happy in the home. In Lincoln County, we've identified the population is aging, with about a third of the population over the age of 60, and half of that population is age 60 to 69. So there's going to be increasing demand as we move into the future. Comparing health statistics with nursing home populations and overall populations determine that there is a potential need within the market right now of somewhere in the vicinity of 112 to 150 people. So right now we estimate that there's this amount of people, up to 150 people, that need some sort of support in the home that don't have it currently. Half of the population we identified in need is split between what we call urban and rural. So urban is simply the population that's centered around the specific cities such as Davenport and Wilbur and others. And the rural population is spread vastly throughout the community or throughout the county. So really identifying and delivering those services remotely is going to cut costs substantially and increase satisfaction. Currently, compared to competition, Lincoln Hospital is in a very unique position. They're municipally funded, which means that they are funded by the county and under the direction of board of directors that is freely elected from the county. So they have people within this community have a vested interest within the hospital's success. Additionally, they're the only providers in the region. All other providers have to commute to the region to deliver care. Now, the model is a remote model, and it is potential for them to deliver care in the means that we are trying to, but not entirely so, because we are trying to use structures and facilities, and also it's directed underneath the primary care physician, which really adds that component of longitudinal care which no other facility can address. Potentially moving into the future, it could be an area that nursing homes want to get into, but at present nursing homes are simply trying to stay above water due to the cost comparison between Medicaid and private pay. If their Medicaid payment, because it's on a pure cost basis, gets too high, then they simply go out of business. So right now, the only potential competition is not poised to even consider expanding into new markets. For sales and marketing, there's only two real methods that we've identified that would be appropriate. We've identified that this is on a need basis determined by the primary care physician, which adds a position of authority and legitimacy to the program. It adds value in that there is an already established trust. Additionally, since it's a small community and there's few places to buy groceries, we see word of mouth advertising as being the main method to talk about and get the service out there. It's called, unquote, unquote, the Safeway effect. So we hope to bring those influential people within the community into the development process and hopefully spread that through the Safeway effect. Management is hierarchical and functional capacity. The program would be under the already established care coordinator and facilitated, as we mentioned before, by the primary care physician. On a cost basis, this is in comparison to Medicaid reimbursement. This cost structure for this program comes in at about half or under half of what would traditionally be reimbursed for this piece in a long-term care facility. Now, on top of that, the patient or the family has to pay another $30,000 to keep their family member in a long-term care facility on average. So the potential savings and the potential value is really there to empower the patient, to keep them at home, keep them safe, and really cut costs at the same time. The added value to this is that Lincoln Hospital is really just transferring services over. So it's folded within their already capacity to deliver services. And the value is substantial. For the population we've identified, say 112,000 people, if reimbursement remains the same, there's a potential value of somewhere between the vicinity of $80,000 to $100,000. So at present, we are currently in talks with the Empire Health Foundation for funding to run trials on this program to establish the basic metrics and quality components of the program. We are hoping to potentially roll this out across the entire Northwest region of rural counties and are negotiating somewhere between the vicinity of $500,000 to $2.5 million to push this program forward. We've identified partners and built those relationships, and also established partnership with the Baldrige Foundation to bring in that quality component and kind of run alongside this program to distribute it effectively across the different rural communities. And this is my business proposal for Washington State University's OMBA program, and I thank you for your time.